Well, great. Well, thank you so much for having me. I'm very excited to be here and be able to speak with everybody tonight. I just want to thank again the Valley for allowing me to give this talk tonight. Again, my name is Erik Zachwieja. I'm a orthopedic surgeon with a specialty in minimally invasive and robotic assisted hip and knee replacement. I work with Garden State Orthopedic Associates. I'm a partner there. So we have several offices throughout Bergen County and North Jersey. And then I do the majority of my surgeries, particularly all of my joint replacement surgery at Valley Hospital in Ridgewood. So tonight we're going to be talking about my aching knees. And so, I think the plan is that I will go through my talk, and then at the end, I will answer some questions. This is going to be recorded, so the plan will be to answer all of the questions at the end, but please leave questions throughout the talk, and we'll get to them at the end of the talk. So we're going to start off just talking about and trying to understand some basic common diagnoses about the knee and understanding general knee pain. We're then going to talk about different treatment options for these multiple diagnoses. Then we're going to focus a little bit on my specialty, which is joint replacement surgery. So we'll speak about knee replacements and then talk about the surgery, what to expect, and then also what to expect from a recovery standpoint. And then again, as I mentioned at the end, we'll go through some questions, hopefully. So, as I think we all know, your knees are involved in pretty much every activity that you do on a daily basis. And, whether that be, up on your feet, going to the grocery store, doing activities around the house, or even sitting at your computer. If you've ever had knee pain, you know that even being seated and feel like you're not doing much, you can still, those knees can really let you know that something's going on. And so a disease or injured knee can really limit your ability to do a lot of things throughout the day and can really affect your quality of life. And so having good management strategies for knee pain can obviously be a tremendous way to help improve quality of life. Now, I'm going to really break this talk down into two separate parts. One is going to be talking about traumatic knee pain, and then we'll talk a little bit later and focus on degenerative knee pain. And so first, we'll start with the most common causes of traumatic knee pain, and that's going to be any form of injury that leads to knee pain. So whether that be a fall, an accident, some sort of twisting injury. And these type of injuries typically result in most commonly either a knee sprain or contusion, which is going to be your kind of basic general diagnosis for banging up your knee, resulting in some pain and swelling. Now, we'll talk a little bit about meniscus tears, ACL tears. We'll very briefly touch on different fractures that you can have about the knee. And then we'll also touch briefly on overuse injuries or injuries that occur when you increase your activity level to a point that maybe your body wasn't quite ready for. And so first, I just want to show you very briefly the basic imaging studies that we use either in the office or we send patients for that give us the bulk of the information that we're able to use to diagnose and develop treatment plans for patients. And so almost every patient that comes into my office complaining of knee pain is going to get plain x-rays. And obviously, we're looking at the bones in the joint when we look at x-rays. They show both the thigh bone, the shin bone, and then the kneecap. And really what we're looking for in general, other than fractures, is the level or degree of osteoarthritis, which is wear and tear of the cartilage. And in general, in between the thigh bone and the shin bone here, you should have a nice black space. And as we progress here to the right, we can see that as you lose that space and you have bone on bone, that's a sign of osteoarthritis. And so that's really going to dictate very often treatment strategies for patients. Now, we always start with plain films. That's easy to get. That's quick and cheap in the office. And that shows us the bones. If we're concerned about soft tissue injury, whether that be the ligaments or the tendons around the knee, that's when we order an MRI. Obviously, that's a little bit more expensive, and that can't be done in the office. So we reserve that for when patients have failed conservative treatment and remain symptomatic. And that often will be able to identify other diagnoses and help dictate management plans. So first, I just want to touch on knee sprain or contusion. This is going to be your most common type of injury, and this usually involves some sort of traumatic fall or twisting mechanism leading to pain and swelling. And really, the diagnosis of a knee sprain is that in which a patient has subjective pain, but objectively on imaging, either radiographs, CT scan, or MRI, there's no findings of anything torn or broken. And so typically, this is a self-limiting condition that will improve with time, but obviously there is treatment to help expedite that process. Patients often present with some sort of swelling about the knee and tenderness to a particular area about the knee. Usually you're able to bear weight on the leg, although it may be painful, and usually you are able to bend the knee, although again, your range of motion may be limited secondary to pain or swelling. And as I mentioned, x-rays will typically be normal and won't show any signs of arthritis or fractures about the knee. Treatment for knee sprains or contusions is pretty basic, and you'll see this throughout the majority of my diagnoses. Is we always start with what we call conservative care. And conservative care involves physical therapy, focusing on strengthening the muscles around the knee, as well as maintaining and improving range of motion of the knee, which oftentimes can really decrease the stresses going through the joint itself and can really dissipate pain. We talk about activity modification, which basically means avoiding activities that aggravate the pain. Common sense rule, essentially. And then NSAIDs, or non-steroidal anti-inflammatory medications. That's going to be your Advil, your Motrin, your Tylenol, Aleve. These are very effective at reducing pain associated with inflammation, which is the result of a knee sprain or a contusion. And as I mentioned, most times pain will improve with conservative care. In general, younger patients may respond a little bit quicker, and older patients, pain may persist a little bit longer. But as long as we're seeing gradual improvement, we usually don't have to worry too much. But if pain isn't improving, that's when we'll often go for further diagnostic imaging, such as an MRI to rule out anything that's torn or broken. Next is meniscus tears. Now, this is a kind of a busy slide, and it really goes through the different types of meniscus tears. Now, I don't think this is necessarily very critical for the layperson to understand. I really just want to highlight that there's a variety of different types of meniscus tears, and really what that means is that all meniscus tears are not equal. So, one patient can have a certain type of meniscus tear that requires surgery, and the patient can do quite well after that. Well, that doesn't mean that everybody needs a surgery for a meniscus tear. And so you really have to understand the type of meniscus tear and the setting of what else is going on in the knee to determine what type of treatment is appropriate. And so I think the best way to understand meniscus tears for the general population is to really break it down into those of acute meniscus tears and those of chronic meniscus tears. Acute meniscus tears are typically traumatic in nature and usually are in the younger population. And these type of tears are most amenable to surgery and most amenable to an acute rehab and recovery phase. Chronic tears are more degenerative in nature and are typically present in the older population. And degenerative tears rarely require surgery and usually are a secondary consequence of another pathology. And then usually what that means is a meniscus tear is the consequence of osteoarthritis. Because if we think about how the knee functions, we have the thigh bone and the shin bone with the smooth cartilage on the end of the bones, and that helps them rub smoothly together. And then in between those two bones is the meniscus, which is the shock absorber. And unfortunately, as we age and we lose our cartilage and we expose the bone in the knee joint, those are two rough surfaces rubbing together. So by nature, the meniscus, which lives in between those two bones, is going to get torn when you have two rough surfaces rubbing together. So surgery to fix a torn meniscus in the setting of arthritis will not usually be effective, because the problem is not that the meniscus is torn, it's that you have two rough bones that are rubbing against that meniscus, resulting in a torn meniscus. So the importance of understanding this is that not all meniscus tears are the same, and that the treatment is really more indicative of the type of tear and what else is going on in the knee. But in general, we always try and start off with conservative management, again, in regards to meniscus tears. So similar to what I said before, physical therapy, anti-inflammatory medication, and activity modification can be very beneficial in reducing the stresses going through the knee, and oftentimes can really improve symptomatic management. Now, when we do think about surgery for meniscus tears, that's when we talk about arthroscopic surgery, and that's when you have the two small incisions on the knee where we stick a camera in there, take a look around, and then address the meniscus tear if necessary. And in general, the most common type of meniscus surgery is what we call a partial meniscectomy, where we clean out or take away part of the meniscus, the portion that's torn, that is flapping around and is irritating the knee joint. Occasionally, in younger patients, we can repair the meniscus, but that's going to be a little bit out of the scope of this talk. And one thing I do want to highlight is that we really try to preserve as much meniscus as possible, because as we've seen from quite a bit of literature, the more meniscus you take out, the higher the risk of the development of arthritis. So this was a landmark study that was performed in the 1960s that really showed that if you have a torn meniscus and you take the meniscus out, early on, patients do very well and their pain improves. But if you look long-term, up to 10 or 15 years later, almost all of those patients went on to develop osteoarthritis. So this was really one of the major studies that helped us understand the importance of the meniscus, and that while it might cause pain if you tear it, if you take the whole thing out, it's going to lead to some major consequences in the future. So whenever we do an arthroscopic surgery, we try to preserve as much meniscus as possible. This is another study just kind of highlighting that same fact, but more importantly, it also indicates that in the setting of a meniscus tear, the goal of surgery is not to necessarily reduce the risk of osteoarthritis in the progression in the future, but it's to acutely reduce pain. So even if we do an arthroscopic surgery in the setting of a meniscus tear, there is still an increased risk of the development of osteoarthritis, whether or not we do the surgery. So our goal is to acutely reduce pain to help return a patient's previous level of functioning, but they still are at an increased risk of the development of arthritis because of the damage to the meniscus in the first place. The patients that benefit most from an arthroscopic meniscectomy are typically going to be younger patients who have symptoms for short periods of time and who have no evidence of osteoarthritis. So the key point I want to highlight here is that if in the setting of patients who have osteoarthritis, an arthroscopic surgery is not a good choice, because patients typically do not have good outcomes. And in fact, there's quite a bit of new research showing that patients actually may be worse off. So it's very important to understand what else is going on in the knee other than just the meniscus tear. Okay, just briefly, I'll touch on ACL tears. These are typically more sports-related injuries happening in athletes, and this is when you feel a pop and you have a lot of swelling in the knee, usually some form of non-contact injury. In general, these are treated surgically with an ACL reconstruction. In older patients who aren't high demand, who don't perform high activity sporting events, you actually can survive quite well without an ACL. But in any sort of high level athlete, we do repair these surgically. One thing I just want to highlight is that whether or not you do reconstruct your ACL, if you do have an ACL injury at some point in your life, your risk of the development of later arthritis is much, much higher, about 3.5% if you have surgery on your ACL, and about 5 times as high as the general population if you treat your ACL without surgery. So unfortunately, those who do sustain an ACL injury at some point in their life, the risk of arthritis progression is much higher than the general population. Fractures around the knee, obviously these are typically high energy type falls, car accidents, things like that. You can break both the shin bone, which is your tibial fracture. You can break the thigh bone, which is going to be your distal femur fracture, and you can also break your kneecap. These almost always require some form of surgery. We fix the bone with metal plates and screws. Again, these are traumatic in nature and are usually addressed in a rather urgent fashion. Overuse injuries, these are very common. We actually saw these quite a bit over the past 2 years, particularly as patients became inactive in the early phases of the pandemic. And then as they increased their activity level throughout the pandemic, we saw patients very frequently coming in complaining of knee pain, and it was secondary to what we would call overuse injuries, because the muscles became used to being inactive, and then as we increase the activity level, they're not quite ready for it yet, and your body responds with inflammation and pain. And there's typically three main areas about the knee where we'll get overuse injuries, and that's going to be above your kneecap, which is going to be your quadriceps tendonitis, but below the kneecap, which is going to be your patellar tendonitis. And these patients oftentimes complain of pain on the front of the knee. It's going to be worse usually with going up or down the stairs and with squatting or kneeling. That's when the most stresses go through the kneecap, and so that's when really those areas are going to let you know that they're angry and that they're inflamed. In general, we treat this again conservatively, so that's going to start out with physical therapy, focusing on strengthening of your quadriceps and your hamstrings. We also have different types of straps and braces that can help reduce the stresses going through the knee. Also, topical anti-inflammatories are effective, and then again, physical therapy. And then another very common type of overuse injury is going to be called your ITB syndrome or iliotibial band syndrome. So while the patellar and quadriceps tendonitis pain typically presents in the front of the knee, your ITB syndrome is going to present with pain on the lateral or outside part of the knee. And so this most commonly presents in runners. Also, patients will complain of pain with pivoting movements, or if they're lying in bed and they're lying on the affected side, they'll have pain on the outside part of their knee. Again, physical therapy is very effective at stretching what we call the iliotibial band, which is a long band of tissue running down the side of the leg. Stretching exercises, anti-inflammatories, and then sometimes we can do corticosteroid injections directly into the area of inflammation to help reduce inflammation and reduce pain. Very rarely do any of these diagnoses require surgery, just kind of activity modification, physical therapy, and NSAIDs almost always resolve the symptoms. So those are the common causes of acute knee pain. Now we're going to spend the rest of the time really talking about common causes of degenerative knee pain, and that's really where my specialty comes into play. And so the three most common forms of degenerative knee pain are going to be three types of arthritis. And so we've got rheumatoid arthritis, which is a systemic disease that attacks when your body attacks all of the joints in your body, and the knee is a very common location. We have osteoarthritis, which is going to be the most common type and form of arthritis, which is your general wear and tear. And that's when the cartilage at the end of the bones, again, the smooth cap on the end of the bones that allows them to rub smoothly together, when that wears out over time, that makes it very painful as the bone rubs against the bone. And then we also have post-traumatic osteoarthritis, and that's when you have a fracture around the knee leading to damage to the cartilage, and then over time we developed arthritis. But we're going to focus primarily on osteoarthritis, which affects upwards of 50 million Americans annually, and that's going to involve includes all body parts, not just the knee. So again, osteoarthritis, it's a common disorder caused by loss of cartilage. While it can affect any joint in the body, the knee is actually one of the most common joints to be affected. It's generally progressive, meaning that over time it does worsen, and usually it presents with pain. It can present with deformity, and patients also often describe stiffness or difficulty moving the joint. It has a very major impact on quality of life and patients' ability to perform activities of daily living. And while arthritis can affect over 50 million individuals in the US, osteoarthritis affects upwards of 27 million. So everybody knows somebody who has osteoarthritis and suffers from it. There's a multitude of causes of osteoarthritis. Some of them are genetic, some of them are patient-related, meaning they're modifiable, and others are things we just can't change. So obviously genetics you can't change, your age you can't change. Obesity is a very common reason leading to osteoarthritis, which is modifiable, meaning that if we can reduce our weight, we can really have an impact on the development or the progression of arthritis. Now, how do you know if you have osteoarthritis? Well, generally, when we're talking about the knee, you're going to complain of pain that is activity related, meaning the more you do, the more you feel it. And usually if you're at rest, it doesn't bother you. Usually it is progressive, meaning over time it does worsen. And oftentimes night pain is very common, meaning you're active throughout the day, and then when you're in bed at nighttime, it will ache and be sore. Again, stiffness is very common, meaning your range of motion is diminished. And then sometimes you develop progressive deformity of the knee, and you may develop what we call a bow leg or a knock knee, and that's as the arthritis progresses. Arthritis progresses in everybody a little bit differently. Some people, it can be very rapid and go from a very mild to very severe rate within 6 months to a year. Other people, it can take 10, 15, 20 years to progress. And there's really no way to really predict that. So here's some pictures that can really demonstrate what osteoarthritis is. First, here on the left are radiographs. So that there's a normal knee, which shows the thigh bone, the shin bone, and then the black space in the middle is going to be your healthy cartilage. Here on the right, we see an arthritic knee where we've lost that healthy black space, and now we have bone rubbing on bone. And this diagram here on the right just is depicting those same images where we've lost that blue cartilage on the end, and now we've got bone rubbing on bone. And we can imagine how painful that would be. In addition to the pain, patients are going to have feelings of stiffness, so difficulty kneeling, difficulty bending, difficulty using the stairs. I often describe to my patients, it's kind of like Rice Krispies in there, where there's lots of popping and clicking and crunching as you bend the knee. That's the rough surfaces rubbing on the rough surfaces. And as I mentioned just a minute ago, you also might notice that legs are beginning to become bowed or knock-kneed, and that's the progressive deformity as the cartilage is lost and the bone is worn away. And that typically happens more later in the disease process. So is there a cure for osteoarthritis? Well, unfortunately, in 2022, the answer is no. If someone does figure out a cure for osteoarthritis, they will be a very rich woman or man. All of our treatments now are really aimed at treating your symptoms, meaning managing the pain and managing the stiffness. And then our surgical options, while they are the only ways to actually cure the arthritis, and that's by removing it and replacing the diseased cartilage and bone with metal and plastic. So how can you relieve knee pain without surgery associated with arthritis? Well, first and foremost, we're going to again discuss those conservative treatment options. So exercise and physical therapy are paramount and are always the first things that we start with. So strengthening the muscles around the knee, increasing range of motion and flexibility are critical, and they really do reduce the stresses that go through the knee joint and can be tremendously effective at reducing the associated pain. And this is usually most effective in the early to mild stages of osteoarthritis before it becomes bone on bone, because actually when you become bone on bone, the exercise can oftentimes aggravate symptoms rather than help it. So if you know that you're in the early stages, exercise is a very effective modality at managing symptoms. Another tremendously effective modality is weight loss. So we put it between 3 and 5 times our body weight that goes through our knee joint with every step that we take. And so if you can even lose 10 pounds, that's potentially 50 less pounds of force that's going through your knee joint. And that can really make a big difference when it comes to stresses and then subsequently the pain that you feel in that joint. So we always encourage patients to lose weight, not only as a means to reduce the risk of the development of osteoarthritis, but once you've developed osteoarthritis, it can really help with the associated symptoms. There's a multitude of different medications that we oftentimes prescribe for the treatment of osteoarthritis. And in general, these are under the category of NSAIDs or non-steroidal anti-inflammatory drugs. And they're really effective because they do 2 things. Number one, they actually treat the source of the pain, which is inflammation within the knee joint. And then number 2, they're obviously pain relievers as well. So we have over-the-counter pain relievers, which are your Tylenol, ibuprofen, Aleve. These are over-the-counter. These are very effective. And then we have prescription strength anti-inflammatories as well. Examples of these are going to be meloxicam or Mobic, as well as diclofenac or Celebrex. These are a little bit stronger, but just as effective as the over-the-counter medications. Injection therapy is also a very good treatment option in the early to mid stages of osteoarthritis. We have a variety of different injections that we offer. We offer cortisone injections, which is a type of steroid that we inject into the knee Steroids are potent anti-inflammatories, again, which the source of the pain in the setting of arthritis is inflammation. So if we can control and reduce the inflammation, then we've really helped manage the symptoms. So cortisone injections can provide acute pain relief and reduce inflammation. Unfortunately, they typically don't help much with range of motion because that's more of a structural problem than an inflammation problem. Patients oftentimes ask, how long are these cortisone injections going to help? It really depends, and it's variable between patients. You can get a few weeks of worth of relief, or you can get several months worth of relief. But in general, they do tend to follow the law of diminishing returns, meaning the more often you have injections, the less effective they are. Another very effective type of injection therapy is viscosupplementation injections. Now that's a form of hyaluronic acid, which is basically a compound that's found in cartilage, and it's part of the, that creates the smoothness of the cartilage. So we inject an artificial hyaluronic acid into the joint, which acts as a lubricant, or I often describe it as somewhat of like a motor oil, helps keep things moving smoothly. And again, that can help reduce pain as well. These are often injected in a series of 3 shots once a week for 3 weeks, and they usually can give relief up to 6 or 9 months. Again, they tend to follow the law of diminishing returns. So the more often you do them, the less effective they become. And typically when you're bone on bone, the effectiveness is diminished. Another type of treatment option is that what we call a genicular nerve ablation. So there are multiple superficial nerves around the knee that basically send to your brain signals of pain. And these are called your genicular nerves. And so the idea behind genicular nerve ablation is that if we burn those nerves and they're no longer able to send signals to your brain of pain, then you shouldn't have any pain around the knee. And in fact, it is very effective in a subset of patients. The way that this works is we usually send you to a pain management specialist. And first they perform what we call a nerve block, where they inject medicine around those specific nerves. And if you obtain significant pain relief, then they go ahead and actually perform the ablation, where they burn those nerves. Now, pain relief, the nerves unfortunately do end up growing back. So the pain relief is only temporary, but it can provide some pretty substantial relief for 6 months to up to 2 years. Again, though, as the arthritis progresses and you become bone on bone, there's other nerves within the knee joint itself that we aren't able to address that continue to send signals to the brain. And so this is not something that can be fully curative. Okay, so now that we've talked about all of the conservative treatment options, is surgery right for me? So when patients come in, they have a diagnosis of osteoarthritis, and they've been dealing with it for quite some time, and they ask, is surgery the next step? I always ask them, have you tried all of these things first? So have you done physical therapy? Have you performed, are you a regular exerciser? Have you attempted weight loss, or have you lost weight, or can you lose weight? Sometimes it's difficult because, we tell you to exercise, but then obviously you have knee pain, so it's difficult to exercise. And so it's this kind of self-begetting cycle where you can't do one thing because the other thing is bothering you. And so sometimes you have to address the knee pain before you're able to get back and exercise. But have you tried to lose weight? Have you tried anti-inflammatory medications? Have you tried injections? And if you've tried all of these things and you're still in pain, the next question is, how is your quality of life affected? So are you unable to do the things that you want to do, you need to do, and you enjoy doing on a daily basis? And if you're unable to do those things because of your knee pain, your knee stiffness, then it's probably time to consider the next step. And that next step is knee replacement surgery. So let's talk a little bit about knee replacement surgery. Now, there's basically 2 types of knee replacement surgery. We have partial knee replacement and total knee replacement. A partial knee replacement involves only replacing the part of the knee joint that's affected by the osteoarthritis. So there's a subset of patients that only have osteoarthritis in one side of the knee. But we basically have 3 compartments of the knee. We have the inside, we have the outside, and we have what we call the part under the kneecap. And if you only have arthritis in one part, we can do a partial knee replacement. If you develop arthritis in the entire knee, then we need to do a total knee replacement. Currently in the US, about 600,000 knee replacements are performed each year. Projections show that in about 2025, that number is going to grow to 1 million. So this is a tremendously common procedure that a lot of people undergo, and it's a tremendously effective procedure. So when talking about the partial knee replacements, we can see here, again, you can have arthritis only on the inside part of your knee. You can have it only on the outside part of your knee. You can have it under the kneecap, or you can have it globally throughout the knee. And so if you have it isolated to one compartment, you're oftentimes a good candidate for a partial knee replacement, which is a great choice because the recovery is shorter and the knee feels a lot more functionally sound. We're gonna focus for the rest of this talk primarily on total knee replacement, but because that's the much more common procedure. About 85% of knee replacements done in the United States are total knee replacement. Only about 15% are partial. But if you are a candidate for a partial, it's an excellent surgery. So here we can kind of see an X-ray depictions of what a partial knee replacement looks like and what a total knee replacement looks like. We can see that the end of the bones have been capped with titanium, and then there's plastic in between the two bones that allows them to articulate smoothly together. This is what the replacements look like in more picture form. Here is a partial knee replacement, and here's a total. These are the metal is titanium, and then the plastic in the middle, or the white here, is what we call highly cross-linked polyethylene. It's basically a tremendously good wear-resistant plastic. So when we're talking about knee replacement surgery, how long does the surgery take? So in general, the surgery takes about an hour to an hour and a half. You're obviously in the operating room a little bit longer because of getting you in there, doing the anesthesia. The surgery itself takes about an hour and a half, and then waking you up from anesthesia. So usually in the operating room about 2 hours. Patients often wonder whether they need general anesthesia, and in most cases, the answer is no. We perform most knee replacements now under spinal anesthesia, so that's similar to an epidural, where you get a one-shot injection of anesthesia into your lower back that numbs you from the legs down, and then the anesthesiologist provides you with basic sedation that puts you to sleep so that you're not aware of what's going on, but you're breathing on your own and you don't have a breathing tube. Spinal anesthesia is a huge benefit for patients and for the surgeon as compared to general anesthesia because it reduces nausea, it reduces urinary retention, it reduces pain and narcotic consumption postoperatively, and it allows you to be up and walking only a few hours after surgery, meaning that you're on the road to recovery sooner. Most patients following knee replacement stay in the hospital for one night and they go home the following day. In my practice, that's about 75% of my patients. About 25% of my patients, these are usually the younger, healthier patients, usually in their 50s or 60s, they're able to go home the same day as surgery. So when we talk about going home after surgery, what does that mean? Well, the goal of in my practice and the trend throughout the country is really to discharge patients to their home following surgery, and usually on postoperative day 1. The trend 5-10 years ago was to send patients to rehab facilities. We've really gotten away from that because the home is a much safer place. There's a lower risk of infection, and in general, you have a faster recovery, and you're forced to be independent, which really helps you kind of force yourself to do things that you need to do to get better quicker. And when you're reliant on people around you and reliant on other people to do things for you, it's a lot easier to get lazy, and that's not good when we're talking about recovering from elective joint replacement surgery. And so when we look at patients who are discharged home as compared to those who are discharged to rehab facilities, we see a significantly lower rate of patients being readmitted to the hospital when they're discharged home as compared to going to a rehab facility. And we see equal or even better outcomes in patients that go home as compared to rehab. Now, when talking about going home, what is the biggest predictor of going home versus going somewhere else? And it's really patient expectations. So if patients oftentimes come in and expect to be going to rehab when I have a meeting with them for their preoperative evaluation, and I really have to break that expectation and tell them that this is a well surgery, you're a healthy person, and you're going to go home after surgery, and that's where you're going to do your rehab. rehab or rehabilitation centers, skilled nursing facilities. Those are for sick patients, and this is a well surgery. So we want to get you back to your house, back to your way of life in a functional way, and the best way to do that is to get you home as early as possible. Now, what we typically do when we discharge you home is we send you home with home PT. So for the first 2 weeks after discharge, you have a therapist that comes to the house every day and does basic exercises with you. Make sure that you're on the right path and road to recovery. But you don't need care 24/7, what your rehab facility provides. You need care for maybe an hour a day, and that's why it's nice to have family members at home as well to help you with basic activities. And patients oftentimes also ask about stairs and are they safe to use? And yes, you'll be using stairs the same day as surgery, and it's very safe. You have no limitations on using stairs. It may be a little bit uncomfortable, and you probably have to take it slow, but you'll have there's no reason that you can't use the stairs immediately after surgery. Again, we do physical therapy at home for the first 2 weeks. So how long does it take to recover in full from a knee replacement surgery? Well, you should expect to walk with a cane or an assisted device for about 2 weeks following the surgery. By 6 weeks, you should really be walking almost normally without any limp or any assisted device. You may have some mild persistent pain and swelling, but that's going to be normal, and that's going to be something that's improving on a daily basis. And I tell patients that by 3 months, you should be 90% recovered. It'll take a full year to get that last 10%, but the vast majority of your recovery is done in the first 3 months. A common question patients often ask is when they can drive, and it depends a little bit on which leg it is. So the right leg may take a little bit longer than the left, but in general, it's between 2 and 4 weeks. I occasionally have patients that'll be driving a little bit less than 2 weeks, but in general, I think 2 to 4 weeks is a safe time frame. I don't give you any hard number. It's really when you feel safe and you feel comfortable, and you know that you can hit the brake when you need to, and as long as obviously you're not in any pain medications that cause drowsiness. When can you return to work? So if you have a sedentary job, most patients are able to return to work between 3 and 6 weeks, maybe even sooner if you're really just at a desk. And obviously, if you work from home, which has obviously become more commonplace these days, you can start work even sooner. A more demanding job that requires you to be on your feet for the majority of the day, typically going to be closer to 2 months. And any sort of really laborious type job where you're doing heavy lifting, that's going to be more like 3 months. Will you need outpatient physical therapy? Absolutely. All of my patients get inpatient physical therapy or home physical therapy for 2 weeks. I see them in the office at 2 weeks for their postoperative check, and then we send them for 6 weeks of outpatient physical therapy. By that time, most patients achieve the functional recovery that they require, and no more physical therapy is necessary. How long will a knee replacement last? Well, I really like to think about this in terms of failure rate. I think a common dogma is that these things fail in 10 to 15 or 20 years. And that was really based on our old technology, our old implants. Our newer implants, I like to think about it in terms of failure rate. So the current data suggests there's an annual failure rate between 0.5 and 1% per year. So what that means is that if you have your knee replaced today, in 10 years, there's a 90 to 95% chance that it's still well functioning. In 20 years, there's still an 80 to 85% chance that's still functioning. So in 30 years, still upwards of 70% chance that's well functioning. So the vast majority of patients, their implant outlives them. So about 85% of patients who undergo a knee replacement surgery, their implant outlives them, and they never need to have it revised. What will your new knee feel like? Well, the goal of knee replacement surgery is to provide you a better version of your current knee. So that doesn't mean that you're going to have a brand new 20-year-old's knee. It's going to be a pain-free functional knee that allows you to perform all of the activities of daily living, all of the basic exercises that you do on a regular basis in a pain-free functional way. You'll probably always know your knee is a mechanical knee. We haven't quite figured out how to prevent that quite yet, but it allows you to perform all the things that you need to do in a functional way and in a pain-free way. Now here, how do I do my knee replacements? I use a robotic assisted technique, and that's something that we do at Valley Hospital. We have three robotic assisted or robotic instruments that allow us to perform robotic assisted total knee replacement. And so we use what we call the Stryker Mako smart robotic system. And here on the right is just a picture of what it looks like. What are the benefits of the robotic system? Well, first and foremost, it allows us to be tremendously precise in our bony cuts. So when we remove the diseased bone, we have to cut it out with a saw, and that can be prone to human error, of course. And so the robotic technology allows us to be precise to the 0.5 millimeter with regards to our bony cuts. Additionally, it allows us to protect all of the tendons and ligaments around the knee from the saw, because the saw is aware and the robot is aware of all of the bony anatomy, so it's able to stop. And that's the proprietary technology of the Mako system, is that the saw actually stops whenever we get outside the boundaries of where the bone is. So it's a safer procedure, and it's a very much more precise procedure. And because of that, it allows us to make a smaller incision, which aids in quicker recovery. The Mako system is actually the most tried and tested of all the robotic systems out and on the market today. It's been around for over 15 years. And these numbers are from 2019. I think we're probably upwards of 1 million Mako procedures performed in this country. So how does it work? Well, I've got here a brief little video.
Let's take a look at how it works. It begins with a CT scan of the knee joint. A CT scan is a series of x-rays taken at different angles that can help surgeons see things that they can't typically see with an x-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create the personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, a knee implant is inserted into the joint space. And once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
So that's a wonderful video and depiction of really exactly how we as surgeons use the CT scan and all of the information to really make precise cuts, and again protect all of the soft tissues to prevent the potential for iatrogenic or human error leading to poor patient outcomes. And so when we look at data with robotic total knee replacement, we can really see that it does improve pain levels at 2 weeks and 6 weeks post-operatively. And then what I really think is very important with regards to the robotic system is this idea of the forgotten joint score. So we have a score in the orthopedics that we call the forgotten joint score that basically looks at what percentage of patients forget that they had their joint replaced. So at some point after you have your joint replaced, you're walking around one day and you just think, hey, I haven't thought about my knee pain in 2 weeks, or I don't even remember the last time I thought about it. and because it just feels so good and so natural. And that's the idea of a forgotten joint score. And when we look at robotic assisted knees versus manual knees, we see that forgotten joint score is significantly higher. And so it really does have a tremendous effect on patient outcome. And so at Valley Hospital, we have 3 robotic systems that allow us to perform all of our knee replacements with this robotic technology. And so last, I just want to mention this one last point is a joint replacement worth it? So a common way to measure the value of a procedure is to compare the cost of the procedure to the quality years of life it gives a person. So what kind of improved quality of life does this procedure provide? And so while the cost of a total knee replacement by itself is quite high, if you look at the objective numbers, when we compare that to the improvement to quality of life, and we have quite a few metrics that we're able to turn that into objective numbers as well, we see that the cost is actually quite low, and patients are their quality of life is tremendously improved after knee replacement surgery, and it's sustained. And so if you ask patients if they would do it again, 9 out of 10 patients say that they would have the same surgery done again to treat their knee osteoarthritis. So that's all that I have for my talk regarding my aching knees and in particular osteoarthritis and knee replacement surgery. So I'd love to answer any questions that we may have at this point. And please, if you haven't asked any yet and you'd like to, please write them in.
Dr. Zay, we do have quite a few in the chat. So
okay, I see. Here we go.
See that, or I can read them to you. What would you prefer?
Yeah, I just pulled them up. I can go ahead through them. So yeah, I'll look through and then try and answer them to the best of my ability.
So while you look through, I'm just going to do a little plug for the library again. Just so anybody knows, if you're a Paramus resident, you will have access to this with your library card. If you're not a Paramus resident, you're welcome to come into the library and we can give you access to our health and wellness database, which offers a lot of wonderful access to medical journals and information to anybody, again, who has a Paramus library card. I'm going to actually put our website in the chat for anyone who might be interested. And we can go through that with you. We got this database based off a grant through the federal government. So of course, we'd like to see it used more and more. It's on the Paramus Library website under Resources, Gale Health and Wellness.
Okay, so yeah, so a bunch of questions here, a bunch of great questions. I see Jerry Zachs asked, he said that he gets gel shots regularly, but he wanted to know when it's time for a knee replacement. I think I probably answered that a little bit later in the talk. But again, the main thing I tell my patients is when you've tried all of the conservative treatment options, which include the physical therapy, the anti-inflammatories, the injections, they're no longer effective. Your quality of life is really becoming affected. And so you're not able to do the things that you like to, you need to, and you enjoy doing on a day-to-day basis because of pain. That's when it's time to consider surgery. He also asked about whether gel shots are available for other joints, such as the hips or the shoulder. While they are available for the hips and the shoulder, our literature with regards to the effectiveness is not quite as good. We have very good data showing that gel shots are quite effective for the knee. Our data is not quite as good for the hips and the shoulders, so they aren't actually FDA approved yet for the hips or the shoulders. Is it true that steroid injections can lead to more harm by eventually drying up the knee? I think what you may be referring to there is that oftentimes people say that the steroid can actually be detrimental to the cartilage, and so should we not should we not repeat them over and over again? Well, in general, that is true that the steroid is detrimental, but that's typically to healthy cartilage. And when we're doing steroid injections for arthritis, we already have diseased cartilage. So we're not really worried about doing more damage to the cartilage, and we're really worried about managing the symptoms. So it's safe to continue doing injections if surgery or other treatment options are not an option secondary to personal or lifestyle or social factors or medical comorbidities. So I would not worry about that if you already have arthritis. What creams relieve pain? So there's a few over-the-counter anti-inflammatory creams. A good one is called Voltaren gel. That's over-the-counter. It has 1% diclofenac inside of it, which is, again, it's an anti-inflammatory. It's typically better for more topical problems. So arthritis, it's not going to be that effective for, but if you have tendinitis, if you have things like that, it oftentimes can be quite effective. And that's Voltaren gel. It's 1% diclofenac, and you can get that over the counter. I have a question about the patient states that his knees seem to be okay when he walks, but if he sits for a while, they get very stiff and very painful. That's actually usually a sign of arthritis. So arthritis can be different in the way that it presents. And in the earlier phases, oftentimes it'll present with stiffness, but not necessarily pain with activity. So my guess in that situation that it is probably some early arthritis. Chris says that he has pain on the outside of his kneecap when he kneels on it. He never has any pain unless he kneels. Unfortunately, Chris, that's really tough to say just based on the history alone. There's quite a few things that could be. That's one of those you'd really have to kind of be evaluated with a physical exam and some imaging. So I don't want to speak kind of out of turn with regards to that one, unfortunately. Sorry, Chris. I think I had two questions revolving doing bilateral knee replacements, meaning if you have osteoarthritis in both knees, doing both knee replacements at the same time. So most surgeons, including myself, have pretty strict criteria for the patients that are candidates for bilateral knee replacement. And that's because, although a knee replacement is a well surgery, it's often done as an outpatient. It is still a major hit to the body. And doing two at the same time it's a tremendously big hit to the body. And our literature does show that the risk of medical complications is significantly higher in patients that have done both at the same time. So my criteria is you have to be younger than 65, and you have to really have no medical comorbidities, and you have to have good social support at home. So those patients are candidates. The recovery is a little bit longer, but obviously you're only undergoing one surgery. Jill asks if all surgeons use the Mako system. Absolutely not. No, currently I think about 10% of all knee replacements in the United States are done with robotic technology. The Mako system is just one brand of multiple different brands. It's the first one and it's probably the most used, but still only about 10% of surgeons use robotic technology in 2022. Jerry asks if it's okay to take Aleve every morning. So anti-inflammatories like Aleve are safe. Obviously, if you overdo them and you take them too frequently, they can cause gastric upset. They can cause GI bleeding. They also can affect the kidneys. So they're very safe for short periods of time. I don't usually recommend them for very prolonged periods of time. And if you have any suspicions or any issues, I would follow up with your primary and ask them, make sure that you have no contraindication to continuing to take them. Faith wants to know if she can wear high heels after a knee replacement. Yes, absolutely. Probably not for the first 3 or 4 months, but once you fully recover, I think that's a very reasonable goal, and many patients are able to get into high heels. A good question by Laura and Jeff. They want to know if they need to slow down on their high impact activities like skiing or running after surgery. I don't give my patients any restrictions on their activity level after surgery. I allow them to do anything that they are comfortable doing. And the reason for that is because that's really the reason we're doing the surgery. We're doing a knee replacement to restore your quality of life, allow you to return to doing the things that you enjoy doing. And the last thing I want to do is do this surgery and then give you a list of all the things that you can't do. So I really allow my patients to do anything that they're comfortable with. Our literature as to whether or not that increases your risk of the need for a repeat surgery in the future is actually quite equivocal. There isn't any good data pointing either way. And so in my opinion, I want to give my patients and restore their quality of life. So I'm not going to give them any restrictions. So anything you're comfortable doing, I allow you to do. There's a question about, if you have a torn meniscus, do the powders, collagen, things like that, are they beneficial? They're definitely not going to help repair your meniscus. Our literature is really not great on any evidence that these things make any significant difference. There's very low risk associated with them, and there's low harm. So I oftentimes say that, hey, why not give it a shot? But I wouldn't guarantee you that's going to make any difference. I think a thing that we might have a few of here is stem cell versus PRP injections. These are, again, other types of injections that aren't FDA approved. There's no evidence to support their use. They are beneficial for some patients, but for just as many patients, they're not effective. And our literature shows that they're no more effective than placebo. Our current literature, we still are doing quite a bit of research actively into this type of topic. And so I kind of keep your eye out for more data on PRP and stem cells. But at this point, they're not covered by insurance, and they're quite expensive. But they are an option for patients who really want to avoid surgery and want to give something else another shot. All right, maybe we have time for one or two more. Debbie wants to know, she has Osgood-Schlatter disease since childhood. Would that have any interference with the knee replacement? No, that would not affect your knee replacement at all. And then Anne, this is a great question. She's 86. She already had her right knee replaced. She thinks her other needs to be replaced, but she's worried because of her age. This is a very good and very common question. So you need to think about age, not in terms of chronological age, but of physiological age. So you could be 86 and be just as healthy as a 55-year-old with multiple medical comorbidities. And so if you're still active and your heart and lungs are healthy enough to undergo the surgery, and your quality of life is really impacted and you're not able to do the things that you need to do, then a knee replacement is extremely effective, and it's an extremely reasonable option. We have very good literature to show actually that patients in their 80s and 90s that undergo total joint replacement have maybe even better outcomes than younger patients. And that's because, their demands aren't quite as high. And so we're able to really restore their quality of life. And as long as physiologically you're healthy enough to undergo the surgery, and that's what your cardiologist and your internal medicine doc are able to answer for us, then you're absolutely a good candidate for the procedure. Okay, I think I've got to pretty much all of the questions. So if there isn't anything else, I just want to thank everybody again for joining the discussion tonight. I hope this was helpful, answered some questions. And anything else that you all may need, you have my information on here on the end of the slide. And I look forward to potentially meeting some of you guys. Thanks so much.
Thank you so much again. We really appreciated it. And thank you very much to Valley Hospital for helping us have these wonderful programs virtually. It's been such a great blessing to have this information, these resources. I know everyone's been appreciating it. So thank you all.
Great. Okay, everybody have a great night.